Hello and welcome to Internal Medicine, where we talk about ER topics and we talk about internal medicine topics. So today we're going to be doing something a little bit different. We're going to be talking about an approach to vasculitis. Vasculitis can be kind of a confounding topic, especially for residents, because it's a rare condition. Sometimes it can be life-threatening, sometimes it can be completely safe, it can be sent home. So we're going to talk about an approach to this, to how to disposition patients, about when they can go home from the hospital, when they're seen in the emergency room, and then how to work them up. Since this differential can be quite vast, we're going to talk about specifically how to screen people with the review systems as well as laboratory work to decide if there's somebody that needs to stay in the hospital versus somebody that can go home. So specifically, we're going to talk about how to improve awareness in residents for creating a differential diagnosis when vasculitis is of a concern. We're going to talk about giving you a roadmap for using common and advanced testing to narrow down your differential diagnosis with vasculitis. And then we're going to talk about how to empower residents to decide about dispositioning decisions, about who has to be admitted to the hospital, who can stay home, and then how to do advanced testing when you're trying to come up with a specific etiology for the vasculitis. Now, I've always had an interest in this topic. I am by far no means an expert, probably on the grand scheme of things. An expert would be somebody like a rheumatologist, kind of at the top of the pyramid. Next line down would be people like pulmonologists and nephrologists, because they're people that specifically treat vascular conditions. Then probably in the hierarchy of things, there's me, which is an internist that probably has a little bit more than an average interest in rheumatological conditions. There's probably your everyday internist. And then kind of at the bottom of the rung, there's emergency medicine physicians that see patients with this, which is why we're going to talk about screening for this and who it's safe to discharge and who it's safe to admit to the hospital. So without further ado, let's get started. So today we'll have a 52-year-old male that presents to the emergency room with a rash that's been worsening for the last week and overall not feeling well. The rash is only apparent on the legs. So first of all, let's talk about what's this rash. That's kind of step one in the differential diagnosis, is being able to identify this. So what this is a cutaneous vasculitis. This can be a problem unto itself, or it can be a symptom of a larger systemic process. So we describe this by feeling to decide if it's palpable or non-palpable, which helps us with our differential diagnosis. So in this case, we're going to say that this is a palpable purpura, is how we would decide that. It differs from a petechial rash in that it's greater than a half a centimeter, and obviously, like I said, it's raised. It can develop over a couple hours, it can be simultaneous, it can be sequential. Generally, this disease resolves over 2 to 3 weeks, and then with the post-inflammatory changes, the legs might be hyperpigmented after the fact. It's gravity dependent, which was why you're going to find it on the legs. So depending on who your patient is, if it's a 3-month-old patient, then you might see it more on the buttock and the back than the legs, because this is the gravity dependent area. In adults, if the patient's bedbound, you might also see it in the back and rather than in the legs. They can have atypical presentations too, where it has papules and plaques that kind of look like urticaria. And then in more advanced cases, sometimes it can present with bulla, vesicles, and necrotic ulcerations. But this is going to be the minority of patients, and generally for things like board exams, they're probably going to present with the more typical rash. There's a range of symptoms that patients can have with the rash itself, where it can be completely asymptomatic, or the patient can complain of burning or pain or itching at the site. Pathologically, on biopsy, leukocytoclastic vasculitis is defined as having neutrophilic infiltration around the vessel with signs of necrosis. Sometimes there's IgA or IgM or IgG immune deposit complexes, which can be found by direct immunofluorescence studies. So when talking about if the rash is palpable versus non-palpable, let's talk about the differential diagnosis for non-palpable rash. So this tends to be more non-inflammatory, meaning that it's a defect hematologically or in the vessel wall itself. So we would consider a differential of things like scurvy or Ehlers-Danlos, amyloidosis. Sometimes steroid purpura looks like this. Otherwise, thrombocytopenia and clotting defects can also present in this fashion. But thrombocytopenia more specifically would show petechia rather than purpura. But sometimes if you have multiple petechia in the same area, it can confluent and look like a purpura. So now that we've defined the rash, leukocytoclastic vasculitis, what's your differential diagnosis for this? And in 2012, there's the Chapel Hill consensus, which gave us a differential diagnosis for vasculitis. Small vessel diseases like ANCA-related diseases, which would be granulomatosis with polyangiitis, formerly known as Wegener's. There's microscopic polyangiitis. There's eosinophilic granulomatosis with polyangiitis, or EGPA, formerly known as Sugar-Strauss. Immune complex deposited diseases are things like anti-glomerular basement membrane disease, cryoglobulinemic vasculitis, IgA vasculitis, hypocomplementinemic urticarial vasculitis. These are all small vessel diseases. Moving up to medium vessel diseases, now we would consider things like polyarteritis nodosa and also Kawasaki's disease. Large vessel vasculitis would be things like giant cell arteritis as well as Takayasu's arteritis. Variable vessel vasculitis is things like Behçet's and Coogan syndrome. And then single organ vasculitises would be simply known as cutaneous leukocytoclastic angiitis or vasculitis. This is the type of disease process. This is the type of thing you can send home because it's just a local disease process in the skin itself. Systemic diseases that cause vasculitis would be things like lupus and rheumatoid arthritis and sarcoidosis. Vasculitises that have a probable etiology would be vasculitises caused by hepatitis C, hepatitis B, syphilis. There's lots of drug associations with vasculitis, as well as many cancers can be associated with vasculitis. So what do we already know about this patient? It's a 52-year-old male that has leukocytoclastic vasculitis. So leukocytoclastic vasculitis is associated more with small vessel vasculitises. Medium vessel vasculitises are associated with a myriad of other skin findings. This would be things like livedo reticularis. It would be things like paniculitis, digital ulcers or digital gangrene on the fingers or the toes, and then things like phlebitis, and this could be superficial phlebitis or something more severe like a deep venous thrombosis. So they're a 52-year-old male too. So let's think epidemiologically about what would be a common vasculitis in this patient. We said it's most likely a small vessel vasculitis, but the most common vasculitis is giant cell arteritis, having an index of about 20 per 100,000 patients, making it the most common. Things like other ANCA-related small vessel vasculitises occur at max 20 per million patients. So we already know they're an adult, so that makes things like IgA vasculitis or Henoch-Schölling's purpura much less likely, although about 10% of patients fall into the adult category with this, where 90% of patients, I believe, are less than 10 years of age. Also, things like Kawasaki's would be much less common since it's an adult. This is the most common vasculitis in Asia. So let's talk about how to use a review of systems to talk about narrowing down our differential diagnosis. So the first thing we should ask about the rash is this a single course? Has the patient had this happen before? Is it a chronic presentation? Is it relapsing? Is it remitting? Single course vasculitises are more common for drug or infection induced. Recurrent bouts with remission are sometimes signs of things like cryoglobulinemia and Henoch-Schölling's purpura. Chronic persistent vasculitises are more indicative of systemic vasculitises, connective tissue diseases, or maybe paraneoplastic conditions. So if the person's presenting after that typical 2 to 3 week course and it's still persisting, then we'd worry more about systemic disease. To decide if this is a systemic process, we should start by asking the patient if they have any constitutional symptoms. So constitutional symptoms includes things like fatigue, fever, night sweats, weight loss. These can be signs of chronic infections. They can be signs of chronic autoimmune diseases. So if the patient is positive for this review systems, then we know we should probably look a little bit deeper. Autoimmune diseases are actually 15 to 25% of cases of fever of unknown origin, which is defined as having a temperature greater than 101 lasting greater than 3 weeks. ENT review of systems. So we should ask about if the patient's been having any nasal congestion, if they've had nasal ulcers, if they have nosebleeds or signs of chronic sinusitis. This would point more to granulomatosis with polyangiitis or maybe eosinophilic granulomatosis with polyangiitis. If the person's had any visual changes like blurry vision, double vision, eye pain, redness, if the patient's having any difficulty chewing or pain with chewing or their jaw kind of wears out, this implies jaw claudication. If the patient's having any scalp tenderness, headaches, specifically temporal headaches, this points to giant cell arteritis which is a large vessel vasculitis. For pulmonary review systems, we should ask if the patient's had any cough or shortness of breath, wheezing, or if they've had any hemoptysis. This can point to small vessel vasculitis, specifically ANCA-related diseases that sometimes have hemoptysis or infiltrates at presentation. This would be, again, granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis. It can also be a sign of anti-GBM disease, which about 50% of patients have pulmonary involvement for. This also might point to secondary conditions such as drug-induced vasculitis can also have respiratory symptoms, depending on what agent was started. We should ask the person about having any cardiac symptoms. Have they having any chest pain? Are they having any palpitations? Are they having any new onset claudication in their arms and legs? This might point more to large vessel diseases with claudication. Things like Takayasu's arteritis often present with diminished pulses, and especially in the upper extremities. It's more common in young females. Chest pain can also be a sign of aortitis, which Takayasu's is, and syphilitic diseases can also cause aortitis. Polyarteritis nodosa can also involve the coronaries and present with chest pain, as well as some secondary conditions can present with things like myocarditis and pericarditis, and this might be a sign of lupus. GI symptoms are kind of unique to vasculitises. So if the patient had abdominal pain, melena, hematochezia, diarrhea, nausea, vomiting, if they're positive on any of these, it really limits which disease process it can be, because not many of these vasculitises actually affect the gastrointestinal tract. So this would point more to Henoch-Schwelling's purpura. It might point to polyarteritis nodosa, which creates a whole bunch of pseudoaneurysms, sometimes can cause abdominal pain, can cause bleeding, bowel infarction, sometimes pain with eating can cause intestinal angina. And then secondary conditions that can cause vasculitis would be things like ulcerative colitis and Crohn's disease. But like I said, GI symptoms are pretty unique, so it narrows down the differential diagnosis. Renal involvement can be quite broad, and it's difficult to kind of scratch at this in a review of systems, but we should ask about if the person has any changes in urine, foamy urine, decreased urine output, flank pain, or new onset hypertension. So if the patient has no history of blood pressure problems in the past, and now their blood pressure is 190 when they're presenting, this may be signs of things like polyarteritis nodosa, or a decline in GFR now creating hypertension. So we'd also have to worry about things like ANCA-related diseases, specifically microscopic polyangiitis or GPA, and then anti-glomerular basement membrane diseases additionally. Cryoglobinemic vasculitis may also present with proteinuria and hematuria as part of membrane proliferative GN picture. Neurological review of systems. So does the patient have any changes in sensation, any numbness, any weakness in the arms and legs, specifically wrist drop or foot drop? Any new severe headaches, confusion, focal neurological deficits. So polyarteritis nodosa is notorious for causing mononeuritis multiplex, which is a condition where peripheral nerves are damaged, resulting in weakness, numbness, tingling in various parts of the body. Specifically, foot drop or peroneal nerve involvement is much more indicative of polyarteritis nodosa. GPA can also present with things like cranial nerve palsies, and cryoglobulinemia as a secondary condition can also produce peripheral neuropathies. And we should ask about musculoskeletal problems. Is the patient having any joint pain, stiffness, swelling? More specifically, if it's symmetrically involved or asymmetric joints, and then as well as the pattern of joints. So inflammatory arthritic pain, which would be more indicative of an autoimmune process. Usually pain peaks in the morning, lasts for greater than 30 minutes. There's some morning stiffness that lasts a few hours and then improves with activity. And does not completely remit with rest. And this is kind of the opposite for things like osteoarthritis and how you can tell them apart. Polyarticular pain, meaning greater than 3 joints, can be rheumatological disease. It can also be things like serum sickness, drug-induced arthritis, Reiter's syndrome, rheumatic fever, Lyme disease. Patients that have more symmetric pattern to their joints involvement would be things like rheumatoid arthritis, SLE, and then also vasculitis, which is what we're looking for today. Asymmetric patterns are more indicative of things like psoriatic arthritis and ankylosing spondylitis. Rheumatoid arthritis is more specifically found in the PIP and MCP joints, So looking there on your patient might give a hint if the person has rheumatoid arthritis as a presentation. Other important history we should ask about is, does the patient have any secondary causes of vasculitis that might be due to infection? So did the person recently have influenza in the last week or two, or COVID? Has the person been sick recently? Would probably be an easier way to get at this. Does the patient have a tobacco abuse history? Berger's disease, thrombophlebitis obliterans, strongly associated with smoking, leads to vascular insufficiency in the extremities. Other things we should ask about is, have they had any recent medication changes? Has the patient been put on antibiotics recently, or allopurinol? Did they recently get started on phenytoin? Are they on methotrexate for some type of secondary autoimmune process? Has the patient recently received a vaccine? Drugs that can induce lupus would be things like, most commonly, procanamide, hydralazine, and isoniazid. At least those are the three most common ones I see pop up on board exams. Other past medical history we should look at: does the patient already have an autoimmune disease? So do they have RA, SLA? Do they have Sjogren's? Do they have polymyositis? Do they already have Crohn's disease or ulcerative colitis? Do they have any history of cancers like lymphoproliferative diseases, myelodysplastic diseases, myeloproliferative diseases? So things like AML, CML, polycythemia vera, essential thrombocytosis. Do they have any history of solid tumor cancers, more specifically lung cancer? Does the patient already have history of hepatitis B, C, or HIV, a chronic infection that might lead to these conditions? And while a review of systems is important to kind of point to a systemic disease, a lot of these diseases have overlaps. This is a table that I've recreated from an old New England Journal article from 1997 that shows the frequency of organ involvement for different small vessel vasculitises. So here you can see, even if one condition isn't necessarily highly associated with a specific system involvement, it might be the minority of patients. For example, like eosinophilic granulomatosis with polyangiitis, only about 45% of those patients have renal involvement, whereas granulomatosis with polyangiitis, about 80% of them do. So eliminating review of systems system that's involved with this doesn't necessarily rule out the disease entirely, is the only point I'm trying to make by showing this to you. So let's look at a basic lab workup for a patient that presents with signs of leukocytoclastic vasculitis, and then how we can use the lab work to help eliminate systemic involvement versus make it more likely. So what should we be looking at specifically on things like a CBC to start with? So let's look at a patient's white blood cell count. So leukocytosis can indicate acute inflammation, possible infectious process. Things like bacterial endocarditis can present with vasculitis. Eosinophilia is obviously associated with eosinophilic granulomatosis with polyangiitis. It's right in the name. Things like leukopenia sometimes can point to an underlying autoimmune condition or possibly viral infections. Looking at the patient's hemoglobin is going to be important too. A lot of these patients, if they've got a chronic inflammatory process, they might have an anemia of chronic disease, so it might make more of if you have other lab work to prove that this is chronic. Acute bleeding could happen from things like alveolar hemorrhage or possible GI bleed, which is why it's important to ask them about that in review systems, and you may see a reflective drop in the patient's hemoglobin. When looking at the patient's platelet count, things like thrombocytosis may reflect a systemic infection, whereas thrombocytopenia might point to DIC, which can be present as pseudovasculitis. The thrombocytopenia aspect of it usually would present as more a thrombocytopenic rash, which would be petechia that would be non-palpable. Looking at a complete metabolic panel, starting with the patient's renal function, obviously if their BUN and creatinine is elevated, generally in a less than 20-to-1 ratio, this would indicate a renal involvement. This would be common in small vessel disease or ANCA-related diseases, so chronic, granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis, and cryoglobulinemic vasculitis presents with membrane proliferative glomerulonephritis. Medium vessel involvement can also point to things like polyarteritis nodosa, which would have an increase in an increase in your BUN and creatinine, and thus a decrease in your renal function, and then anti-GBM diseases. When looking at a patient's liver function, meaning their AST, ALT, ALK phos, bilirubin, doesn't really help much as pointing to a specific cause of vasculitis, but if the patient had chronic elevations in their LFTs, this might point to a chronic hepatitis like from B or C. Coags to check would be important too. Looking at a patient's PT, INR, APTT, we might see some mild elevations in this, but pure vasculitis conditions might have normal coagulation profiles unless there's severe inflammation or concurrent infection. Otherwise, the main thing we would want to screen a patient for in this would be DIC. which, like I said, can present as palpable or non-palpable. Usually somebody would be pretty sick if they had DIC, but proving that they don't have this potentially fatal condition would be important to look at in lab work. Elevations can also point to things like antiphospholipid syndrome if chronically elevated. Some non-specific stuff we could look at would be things like ESR or CRP. They're frequently elevated in vasculitis. It's not diagnostic. It really just tells you that there's inflammation that's happening. So let's talk about how to disposition a patient when vasculitis is of concern. So when presented with leukocytoclastic vasculitis, now that you can identify it, we want to define if this is a systemic process versus an isolated cutaneous process. And that's what our lab work's for. That's what our review of systems is for. So if you suspect a systemic process, then the person should probably be admitted to watch them for any end organ dysfunction or to track that, as well as probably to achieve a diagnosis or do testing that can't be returned within an hour, like in an emergency room setting. If you're pretty convinced that the patient does not have systemic involvement, maybe they just, like I said, had the flu a week or two ago, so maybe you think this is might be related to an infective process that the person's already recovered from. Maybe the patient recently got put on a medication, you think this is a drug reaction, or you think it's idiopathic, which is about 50% of cases of cutaneous vasculitis. So if you think it's local and skin involvement only, you would treat the underlying process, maybe withdraw the drug if possible. You would do things like rest, which involves avoiding standing or walking, elevating the legs, and using compression stockings. You might consider a course of steroids for the patient, which would be prednisone 0.5 to 1 milligram per kilogram per day. This is more appropriate if the patient has a severe disease or they're having severe symptoms for it, the rash is widespread, or the disease is possibly recurrent. But being started on this medication, the patient may be able to be sent home if it's only a cutaneous reaction. Now let's talk about an advanced workup. So this would be somebody that you're concerned about having a systemic process, so they're being admitted to the hospital for a further workup. Well, we'd probably want to start with ANCAs, since we thought a lot of this was related to ANCA diseases, which is anti-neutrophilic cytoplasmic antibodies. So there's ANCAs come in two different flavors. So they come as C-ANCA and they come as P-ANCA. C-ANCA referring to immunofluorescence where the uptake is seen. So it's seen throughout the cytoplasma of monophages or monocytes. This would be associated with things like granulomatosis with polyangiitis. And then there's P-ANCA, which is the pattern is now seen perinuclear. This is points to more microscopic polyangiitis or eosinophilic granulomatosis. It can also be positive in things like drug-induced vasculitis, polyarteritis nodosa sometimes has positive P-ANCAs, and then also inflammatory bowel disease, so things like ulcerative colitis and Crohn's. We should probably check things like an ANA and a rheumatoid factor. ANA can be indicative of lupus, at which if you order more specific testing for that, which would be like anti-double-stranded DNA or anti-Smith's antibodies if you suspect lupus. A rheumatoid factor, this can be positive in cryoglobulinemic vasculitis. It can also be positive secondary to hepatitis C. So you don't even need to have a positive rheumatoid factor in order to say the patient has rheumatoid arthritis. An anti-CCP is much more specific for that disease process. We should probably do complement levels, which is C3, C4, CH50. This would suggest immune complex mediated vasculitis, such as cryoglobulemic vasculitis. Specifically, you would see a low C4 compared to a normal or slightly low C3, and that's indicative of cryoglobulinemia. Higher normal complement levels are sometimes associated with ANCA diseases. Checking cryoglobulin levels, too, you think would be more indicative of cryoglobulemic vasculitis, but usually these levels are, they have a high false negative rate, so not necessarily worth checking. Other testing we would want to do since the person's being admitted is we would probably want to, if there was renal involvement, we would want to screen them for anti-GBM disease. We should probably screen them for chronic infection or chronic infections, things like hepatitis C, hepatitis B, things like HIV, or if the patient had symptoms of syphilis, then we might want to screen them for that additionally. Well, I hope all this was helpful. I know vasculitis can be kind of a confusing topic to go through, especially when considering things like differential diagnosis. So I hope your differential diagnosis has been helped by this, and you can approach the next time you see this rash a lot more thoughtfully. Hopefully you can make disposition decisions about who needs to be admitted to the hospital and who doesn't need to be, and then I hope you get some board questions right when it comes to vasculitis in the future.